Thank you so much for the opportunity. I already learned so much. Also, really appreciate, I always give State Public Health Laboratory a place. So today, what I'm going to address here is the Wisconsin newborn screening for XLD experience. And we are we talk about 10 years and we only did this for the last 3 years. So we are not in the front, but hope our experience can be useful. So I always find an excuse to use these slides, actually a couple of slides in general, because in the newborn screening, we have so many conditions in the panel, so every single time, every single disorder is being discussed, you have to take this into the system. And so I always try to remind everybody, if you are not working in the newborn screening laboratory or the program, and take this into the consideration, adding on disease, not to say today we want that, tomorrow we'll be there. I have a lot of things that need to be taken into the consideration. And also newborn screening, not just a simple test. So it's why I use as a title, newborn screening is beyond the spot. And think newborn screening, think about the system. So start with the, we call it education. It really is people in the family and the OBGYN understand the time sensitivities, understand the quality, the specimen, which is beyond our control. So we need a constantly ongoing the process to education, everybody to be, with us. Another key thing here is the transportation. Compared with the clinical diagnosis laboratory, the difference is we have the time sensitivity, and we need to get a specimen to come in a certain time frame, because when like I said earlier, it's not a single disorders. You always find a weak link. So what condition, we talk about XLD, but we also screening for organic aciduria. That is ours matters. So we ask people really in compliance to do what we ask to do. And we have so many specialists here. Hopefully you guys can help us lobby the primary care physician and the Burden Hospital to try to, when we ask, we have a reason to ask. So the transportation, we general, in our program, we really ask the submitters within 24 hours after specimen collected sent to our laboratory. And in the laboratory, the majority of our work is trying to timely test the testing, and also important is trying to do the best not to lose the sensitivity, also think about the specificity. Because when you do this, the majority specimen, you expect screening negative, and you really don't want give, how I best describe it, let's say trying to avoid the anxiety potentially created for the parents. Because the whole idea is you want to give some parents a certainty, but if we don't pay attention to this testing, how this, we call the positive predictive value, we may unintentionally cause some parents unnecessary anxiety. So that's the we spend so much time on this the exercise, if I'm well, and people in the laboratory medicine will be recognized. If you trying to develop testing, emphasize the sensitivity, you may satisfy specificity. So recent years in the field, people really think about, we call the 2 tiers approach. You have the first tier, quick, inexpensive. You can really let majority specimen to have a lower risk go, then you can do additional testing and help the laboratory have a better performance. So another thing different when talk about newborn screening program, unlikely reference laboratory, diagnosis laboratory is when you do the testing and you give the report, your job is not done. So in the public health setting, screening positive, it's program the obligation, be sure screening positive the infants are followed by the specialties or primary care physician. Also, they will do the confirmatory test as recommended. The testing results have come back to the program. That's how we improve ourselves, right? Without knowing the knowledge, we don't know what we need to improve. So that's different. This is called a short-term follow-up. And another biggest picture is the long-term follow-up. Over the time, and the screening really is do what they're supposed to do. And this is another avenue, and recently has get a lot of attention and to trying to improve. So now I'm gonna get back to, one more thing, timeline. It's compared with the diagnosis laboratory. It's overall, we really want all the newborn screening results within the first week of life. Then in order to do so, you have to have every component have to work their way. So from the birth to the specimen collection, so we hope is everybody really do 24, 40 hours, because a lot of metabolic condition, you want to give a little bit of time, let metabolize build so we can identify them, but not to the point to harm. So this is kind of balance we need to take attention. I talk about the transportation and laboratory testing. The one thing that I want people to appreciate is actually screening positive could potentially take a little bit longer time. Usually laboratory do the testing, they want to verify the results. So they do additional testing. But the one thing is when screening positive, we are not simply just send a report. Actually, we call specialties, we call primary care physician, make sure they make a connection. So afterwards, we will do the follow-up report. So now I'm going to more emphasize on the XLD. So I think everybody here, especially a lot of experts here, know much more about this ideology. The reason I put here, I want to visualize, especially for parents, for the family, is the pathway indicate why we select the marker we selected for newborn screening. So start with the long chain C16, and you have the elongation and get it longer. And the important is they have to go through into the plex hormone to get metabolized beta oxidation. So because the ABCD1 gene defect actually get the ALD, the protein dysfunction, so the long chain fatty acid, very long chain fatty acid cannot go in. That's caused the accumulation, so we utilize this to do the marker for newborn screening. So another slide I put here is intention is visualize. In general principle, we heard so many updates at this meeting, but in general, from newborn screening point of view, we kind of get a little bit understand. We talk the timeline, we talk about the time critical, but I think for the XLD is in favor for our newborn screening. We do have a time to react. And so which is, it's a good thing. Plan the bone marrow transplant is not trivial, right? So here is, we understand the adrenal insufficiency happen much earlier, and the cerebral form a little bit later. That's trying to give us some sensitive in terms of how you manage the newborn screening in each different laboratory. So here's a Wisconsin experience. So we heard in February 2016, and the HAS secretary accepted the recommendation from the secretary committee and adding XLT to the RASP, recommended unified screening panel. Take a while for Wisconsin set up. We heard each program have different challenging, different priority at a given time. So I'm not going to get all the details, but we did start to do some assay development. And a few years later, Wisconsin, we have our own nomination, voting, discussion process, and we do on the March of 12, 2022, we decided to, including in the Wisconsin newborn screening panel, as I mentioned, we started assay development before that time, and just next month we published our assay development, the experience and the paper. Then we started to screening in September 2023 under pilot study, the program. After several months later, we officially put our panel last year, August. So the method we use a little bit different than most program. I want to say maybe we still perhaps the only one doing the method we did. So the time we working with the CDC and with Minnesota Newborn Screening Program together to do our assessment, I do believe, no, I know by fact, Minnesota's use, we call the LC mass spec, and we want to say, can we reduce the time? We use the term called the flow injection method. It's a pretty common method used in newborn screening, and that's our goal. And so I think we are fortunately come to the conclusion, actually the method indeed to our satisfaction. So you can tell from this published paper, and with our colleague in Minnesota Newborn Screening Program, they provide a set specimen without telling us what I expected. We did the testing based on our population data. We can identify all of them. So at the time, we decided screening, the result category have three. First, screening negative is pretty straightforward. And we do have the safe net, we call the screening borderline, which is only maybe two strong words, we would require to do repeat newborn screening before sending them to clinical confirmatory testing. And of course, the screening positive, we would recommend it, the confirmatory testing. Couple unique situations I want to share with you is when we started, we use our population data, anything beyond the mean plus standard deviation. If for 4 standard deviation, we ask repeat newborn screening. If 8, we will say screening positive. But we quickly find out we have more false positives given the setting, so we quickly made adjustment. So our current way is, if the numbers, the concentration C26 LPC, it's a mean plus 6 standard deviation, we will repeat the newborn screening. And the second is we treat male, female a little bit different. Is when female screening in the screening positive category, we do not ask for confirmatory test. Actually, we ask a repeat newborn screening. If repeat newborn screening cleared, we're done. If we still have this the persistent elevation, we will send the clinic to do the confirmatory testing. So that's the way we're doing. Here is the summary of our experience so far. It's 29 months of data. So far, we screened a little bit shy away of 142,000 babies. You can tell male, female is pretty equivalent. So we do, I think Dr. Jana mentioned that sometimes the demographic information that didn't give a complete male or female, but I can assure you, this 27 all screening negative. If we have a question, we will call and find out exactly their male or female. So in this cohort, we have reported 25 screening positive, and including 15 male and 10 female. And this morning we talk about seems like female a little bit less, and to me it's kind of logical, because the female, you only identify them if they have a C26 LPC elevation, right? We know this, the inactivation is supposed to be random, and so I think it kind of makes sense to me. And because we started as a pilot study, we allowed a family opt-out. So here is we have a very, very few families say no. So overall, we have a confirmed XLD9. When I say confirmed XLD in boys, is confirmatory test if you have elevated very long-chain fatty acids, also have a ABCD1 variants identified, we call this as a confirmed, because we know the phenotypically at that time, we may not know. And we also know is the potentially can identify different conditions. Indeed, we have Zerwag syndrome, actually is a PAX6, the gene variants we identified. And 3 false positives, because when the confirmatory testing coming back, very long-chain fatty acid is normal screening for, yeah. In that group, 15, we still put 2 pending. Actually, I think maybe just 1 pending, because I discussed with Dr. Raymond. We have an interesting case, is I would describe the transient elevation of very long-chain fatty acid. And, but it's interesting, through whole genome sequencing, find the variants unexpected. So I think the more work need to be on that. And now I holding the principle Dr. Raymond told me, if nothing relevant to beta organization, the pathway should be false positive. So we're gonna try to utilize this principle. So in the female, and again, the terminology we have discussed, we decide to, for female, one have a very long-chain fatty acid elevation with identified ABCD1 gene variants, we will call heterozygous female with elevated very long-chain fatty acid. We think that's the group, newborn soon, we need to get a family attention. So we do have 2 false positives. False positives. And in that category, very interesting is these 2 cases is when we have screening positive contact a family, and the family immediately told us, we do know females in our family. They declined to further evaluation. And as a program, we feel we should respect the family wish. So we don't push too hard to say, you have to do this, you have to do that. So it will be interesting to see your comments. So overall, I would say is it's feasible to implement XLD screening into the ongoing newborn screening program. And the method that we're trying to do is can achieve this therapeutic value about 80%. And I think for us, we think it's a good rate. We don't want to miss any cases, so we sacrifice a little bit on the false positive way. So going forward from laboratory test point, and we have two things we want to do, is we know currently XLD screening in Wisconsin is a standalone. So you have dedicated 2 instruments, you have dedicated 2 staff to do that. But in order to improve the efficiency, we really want this multiplexing for other systems. And we have 2 options. One is utilize our routine, the isocounting amino acid method, and that will be require switch, we call the mode, positive to negative mode. And we tried a positive mode, and I really think it's a scary me to that, because when you positive mode, our experience potentially you can false positive and false negative. So when the assay go in 2 different directions, it's hard for you to address that. So early on, we immediately said, no, that's not a method we're gonna go for. Another possibility, actually more likely in our program, is because the new condition come into the consideration, and we will do some assay, put all the lysosomal storage disorder together, and plus MLD and CTX condition, and we are just beginning the assay verification and modification process. So more to come. Oh, last but not least, we have genetic counselor students is working on the survey in terms of through newborn screening identify female heterozygous, see how family feel about that. So they do some kind of ongoing survey research project. I cannot advance. Well, my next 2 slides really is an acknowledgement, but okay, yes. First, and I just want to indicate our assay development and validation is through Mentorfee professorship funding, and also our pilot study is supported by CDC grants. And now it's through regular newborn screening fee, so they stay for forever. Also, these things happen, it's not just one or a small group people effort, and you can tell we have so many people involved in this process. And I want to specifically say the 3 physicians here, Jess, Robert, and Jennifer, and they help me together. We get newborn screening for XLD implementation in Wisconsin, the nomination. Thank you very much for your attention.